Let's go over the final case, IVL use in bifurcation lesion. I told you we'll come back with expansion and IVL. Dr. Haroon Faraz, go ahead.
Next. Big screen, okay. Good evening, everyone. Thanks, Dr. Sharma and the team here, directors, for inviting me. So I'm going to keep it very simple. I know it's a long day. Everybody's waiting for the board, so Dr. Sharma will give his concluding remarks. So 5 minutes, my disclosures. So this is an 82-year-old gentleman who was transferred to our facility from a satellite hospital. He presented with unstable angina / NSTEMI. Troponins were positive. And he was transferred to the CT surgical service for evaluation of CABG versus consideration for a high-risk PCI. His prior history, he had a stent to the RCA back in 2016. Other than that, he's pretty active. According to the daughter, he's using the Peloton almost every other day, pretty independent with his activities. So as per the heart team discussion presented at the multidisciplinary team and the consensus that the CABG would not be appropriate, secondary to some mild delirium that was triggered by the sedation. So the surgeons were concerned that that putting him on the bypass would compromise his mentation and make his dementia worse. So the angiogram of the left main system shows Medina 011. Ostium of the LAD has a TAM tract calcific disease. The circ ostium has some moderate disease. So initially we were thinking of a 2-stent strategy versus a provisional strategy. So when upfront, prior to taking the patient to the lab, I was thinking of a Collart versus a DK crush. So in the lab, my fellow tells me, what, I'm not sure if the circ is severe. Let's be more specific. So we put the IVS down. So the MLA is 5.8, and physiologically it's not significant. So we say, what, this is, let's go with provisional. There was data presented at the Euro PCR. We should go provisional. So my fellow is all excited, telling me, quoting me the data that was presented. We should not do 2-stent strategy. I'm like, okay, let's do that. Let's listen to the fellow. So anyway, so we IVS the distal left main circ. We have an eccentric nodular calcified lesion. We say, okay, let's bring out the IVS. The IVS went through nicely, so the shock wave went through. The size of the vessel was 4.5 millimeter, and the left main was 5.5 millimeter. So post IVL treatment, the lesion gave in nicely, very nice luminal gain, and we felt that now we'll deploy the stent and we're out of here. So we use a 4-5 stent from left main to the LAD. And port with a 5 NC balloon. And then after the port, there was a carinal shift. Yep. And now we have to take care of the ostium. So the good thing was that we have the wire, so we were able to rewire it, dilate the side branch, and then able to do a reverse T-stent. Did a final kiss. And Dr. Moreno said, what is the optimal stent? So, we had MSA of 9.8, 90% of the lumen. So we were happy with the angiogram and final kiss and a port with beautiful results. So lessons learned, side branch occlusion post port can happen from the carinal shift. Wire is always helpful to protect the side branch. IVL helps you with stent apposition in eccentric nodular calcium. Dr. Ziad Ali just published his paper on eccentric nodular calciums. I think that helps. And I think always remember to do the final kiss and the port. I think the shock wave helped achieve our MSA, which was 9.8. Thank you.
Great. This was a great case to top off this discussion.